back on the Zero Hour. I am your host, Richard RJ Eskow, as always, and we continue our coverage of the health crisis now with Justin Mendoza. Justin is the advocacy manager for U.S. Healthcare, not United Healthcare, United States Healthcare, Partners in Health. I've known Justin for years in his past iterations, and they are working on pandemic issues right now. So without any further ado, Justin Mendoza, thanks for coming on the program.
Thank you, RJ. It's a pleasure.
Always great to talk to you. And let's start with this. For folks who don't know, what is Partners in Health?
Absolutely. Partners in Health is traditionally a global health organization. We work in solidarity and partnership with governments, local patient groups, and others who are really looking to provide a preferential option for the poor in healthcare. We believe at our core that every human being should be able to take advantage of social benefits like access to education, food, modern healthcare, a right to work, and broadly, a right to health. So with that, we take it upon ourselves to really push and expose social injustices and work toward correcting those systemic forces that really lead to inequalities. And we really focus in on working with the local community to do that. So by training and empowering folks on the ground to tackle big crises. So for us, it's a natural nexus to work on COVID.
It makes perfect sense to me. I guess, the logical next question is, look, in my view, anyway, we had a health crisis in this country before COVID-19, a crisis of uninsurance, a crisis of underinsurance, and so on, a crisis of poverty and environmental factors, a million other things that lead to what I consider a pre-existing health crisis. How are you guys dealing with the pandemic in terms of it just feels so big, right? What are you doing?
Absolutely. You hit it right on the nose. This pandemic hit the US so hard because we're a country and a system that's designed specifically for an epidemic of this proportion to be successful here. We've built a system that is so fragmented that it's very easy for folks to fall through the gaps for all the reasons you mentioned there, all the social support people are missing. And so what we've done is we've stood up something we call the U.S. Public Health Accompaniment Unit. And our unit is really based on working with experts in the field from local, county, sometimes state level health departments and officials, and really giving them the extra support that they need, from connections to academics and researchers who are on the cutting edge of COVID response to folks who really understand broad healthcare systems and workforce. And what we're doing is we're standing up contact tracing and testing programs in states all over the US. This started in Massachusetts with our partnership with the Massachusetts government to really set up a system where we can test as many people who have been exposed to COVID as possible, trace who they've come in contact with, get those folks tested as well, and then connect them to social supports. And that could be in the form of rental assistance, in the form of housing assistance, in general, food assistance, things that already exist in the social spaces and social supports in the state, but that folks weren't necessarily connecting to when they lose their job or when they face other hardships from this outbreak. And so, our belief system is really built on trying to be the connecting tissue between all of these fractured systems so that we can truly build a health system that serves folks.
So this is, you guys call this what? Testing, tracing, and supported isolation or something like that?
Yeah, absolutely. That's the broad category of the approach for controlling a pandemic. We know from infectious disease outbreaks and HIV, tuberculosis, and even Ebola in the field, the key to it is those, essentially those three components. You have to test everyone who's been exposed, figure out how many folks are positive and where they are. The tracing part is essential, since, especially for COVID-19, since it spreads so easily, being able to figure out who else could have been exposed and come in contact with that person, make sure they're tested as well. And then the supported isolation piece is huge. It's one of the spaces that as a nation, we're missing the most. And it's really about making sure that folks have a continuous source of income, access to food and benefits that they need, and to make sure that families, when they do find out that someone's exposed to COVID-19, have options to make sure that they're not going out there and exposing more folks to it, and to make sure that people really have a backstop and a real support from the government.
And again, we're talking with Justin Mendoza, advocacy manager for U.S. healthcare at Partners in Health, and that supported isolation piece. Justin, it's so important, but you're right. It feels huge because it almost feels to me as if that's what society should be doing, and if society isn't doing it adequately, or it minimally, for that matter, then those are how does that work? I mean, where do you even start, I guess, would be my question.
Absolutely. And I've got to tell you, it's something that is it's a long-term battle to get true supported isolation, or in the case of society at large, just getting a true social safety net in the US. And part of the reason that we see COVID-19 as one of those nexus moments where we can really pull in and look at the social determinants of health and really understand it, and bring it into the work in the public health practice, is we've seen already political momentum to move in that direction. House Democrats in the HEROES Act, which passed back in April, and of course, the legislation has come to a grinding halt, as we've seen in the Senate right now, unfortunately. That legislation included funding for testing, tracing, and supported isolation, which hit the minimum of what you would have needed in April to try to get ahead of the curve. And it really was $75 billion split amongst the states, and with some specificity of targets and metrics to reach those underrepresented populations, or those folks who have the least access to the healthcare system, but left a lot of it up to the states to figure out. And of course, that's where we see starting make sense, is really focusing in on how do we at least free up the funds to get this done. And then at the exact same time, in more of our technical work, how do we help state actors understand how to bring in those funds and how to allocate those funds? And that's been a lot of the work in Massachusetts. And it's been a learn as you go process where we've been figuring out, what are people actually asking for when it comes to support when they find out they have COVID-19, and how can we do that in a compassionate way that really helps connect people back? It's been a big learning curve, and Massachusetts is a lucky state where the state has invested in social supports in a lot of ways. But really getting those federal funds, I think, it's where we think the big chunk needs to come in. It's really the support from the top down to make sure that states can implement these programs.
So there were funds allocated that haven't been dispersed at the state level. Is that the situation, or is that in the legislation that is yet to be passed in Washington by the Senate? Where is that money?
Yeah, it's actually both. So there are at this point at least hundreds of millions, if not a couple $1 billion in funds that have already been allocated and haven't been spent yet by the states. It's a mixture in terms of why those states haven't spent those funds. Some states are just figuring out their systems. To speak to the long historic presence of public health systems in the U.S., we failed to set up those systems successfully, right? It's one of the budget items that local and state health departments will go, well, we have to implement Medicaid, but when it comes to having a public health system in place in case an outbreak happens, maybe they don't need as much budget, right? And that's been the old logic. And unfortunately, that's meant that a lot of these systems have to just build up. And so a lot of states just don't have the infrastructure to spend the money on. So we're working in some of those places to help them understand how to get there and what's needed. And then there's also political dynamics at play. I mean, we've got certain wings of conservative thought out there that actually spread the idea that, some of the misinformation and disinformation about COVID-19 that does translating to the local political level. We're facing that in multiple states. And then we've also got the issue of state budgets being so hurt by the economic impacts of the crisis that some state lawmakers are choosing to fill their coffers first and then address public health next, which has also been an issue. But then also the 75 billion specifically, that's in legislation right now and hasn't yet made it through. It's actually caught up in gridlock right this moment.
So, and again, we're talking to Justin Mendoza of Partners in Health. So let's take a state like Massachusetts, where at least there's some movement. How is the money being spent there? What specifically is being done there, just to give us a concrete sense of how this can work?
Absolutely. So the Massachusetts Contact Tracing Collaborative is a partnership that Partners in Health set up with the government of Massachusetts. And in that program, the main thing we've done is hire local contact tracers who really understand the communities that they come from. They speak the languages that are spoken in the communities, and they're able to, help us call cases when they come through. When someone actually, is infected with COVID-19, quite literally, they pick up a phone, dial the phone number, all of this with protected clinical data and everything like that, and we'll talk to that person about what's happened, about their diagnosis, and also about who else they've come into contact with. And then they do the work of calling all the people that are identified there as well. The biggest piece of this is really on that hiring spend, and then also on the technology needed to connect to folks and put it all back into a centralized database and really understand what's happening on the ground and analyze the data. So that's where most of the funds go in terms of that work. Our approach includes a really holistic approach, and we've been building this over time to understand things like, it's scary for a lot of folks to hear that they've come in contact with someone who was positive with COVID-19, or it can be scary if they're themselves positive. And so having, appropriate mental health response and connections back to folks who might be able to talk through, what it's like to get that news and really understand it is a big component of what we train people up for and connect folks back. But then also a lot of those funds are really connected to what we call our care resource coordination part of this, or the broadest term would be supported isolation. And that's the folks who have more of a social work type background, who can connect to, maybe this family, someone lost their job and was doing something as an essential worker, that person needing now income or food benefits or things like that can be connected by our care resource coordinators. So it's really a combination of contact tracing and the care resource coordination, which comes back to staff spending is the major thing that's needed. And one of the firm things that we figured out from this is you have to have paid staff who are trained to do this work to get the most successful results in terms of understanding where people are, having consistent data, making sure everything's secure and the systems are in place.
Well, a lot of people are out of work right now that I'm sure would love to be trained and work in this area if the funds can be made available. And of course, that's a political question at this point in terms of additional funding. Before I let you go, Justin, I wanted to ask about what might be the next big challenge, which is assuming that a vaccine is developed, as well as treatments, remdesivir or whatever. The question is going to come up of the funding, how much will be charged for these vaccines, who will pay it, the production, the distribution, all of those things that cost money and effort and so on. And big pharma is not known for its necessarily altruism in these regards. So do you have any thoughts on that? Are you guys doing anything in that area, or what's your own thinking on it?
Yeah, so I'll share my own thinking on this from working on this, and then also where PIH is sitting. Actually, the PIH part first, which is that we think the vaccine distribution side of this is so pivotal, to get to an economy that can reopen, to get to schools that can reopen safely, to get to, not a semblance of normal, because the world is going to be different as it is now, but getting to a moment where, a lot of things can resume in folks' life and also where essential services can happen, we have to have a vaccine distribution plan that is distributing a safe and effective vaccine that's gone through all the proper checks and all the proper regulations, and then is distributed in a way that reaches the communities that are most vulnerable. I'm thinking about resource poor rural communities. I'm thinking about communities of color that are more highly impacted based on geography, location, income status, and all of the other intersecting issues there. And in order to do that, one of the key components is the price that you brought up there, RJ. And the price is, it's a top tier issue when it comes to vaccines and treatments. We've already seen the pharmaceutical companies like the makers of Remdesivir, Gilead, will price the drug at a price point that is more based on the traditional values of the pharmaceutical industry, right. High profit margins. We know that in the vaccine space, most of the vaccines that are reaching later stages of development are ones that have had hundreds of millions, if not billions, of US taxpayer dollars invested, as well as investments from other countries. And we're seeing already that the US government is not stepping to the plate to demand a low price for those drugs and those vaccines. And one of the companies that's out front has already said that they'll make a profit off of those vaccines developed during this public health crisis. So a lot of the system as it is a status quo, stands ready to make sure that it's very expensive to distribute a vaccine and that it will be hard to make sure that it's equitably done. And so it's incredibly, incredibly important that as we build towards those next steps, we see the government step forward and be willing to, challenge pharmaceutical pricing, be willing to look at alternative models for the monopolies, the patents, and all of the things that they use to keep the prices high. And also that we see, states and others step forward to be able to help people afford the vaccine, even if it was lower cost. We still have a record number of folks who are uninsured in the country. Some of those folks won't qualify for Medicaid in their states. If they have absolutely no coverage and no support in the healthcare system, this vaccine will be priced out of reach automatically. So helping those folks really get connected into the system is going to be incredibly pivotal to our response as we go as well.
Well, thanks for that. And thanks for your great work in that area. Again, my guest has been Justin Mendoza, Advocacy Manager for U.S. Healthcare at Partners in Health. Justin, before I let you go, where can people go to find out more about your work?
Yeah, go and check us out at pih.org under our Stop COVID tab. You can find out information about our public health accompaniment unit and the work that we're doing globally to take on COVID-19. And we're looking for, of course, more of those contact tracers, more folks to join in and to be a part of the work and to advocate for a change as well.
Well, it's really great work and I appreciate it. And Justin Mendoza, thanks for coming on the program.
Absolutely. Thank you.
You bet. We'll be right back after this. I am Richard RJ Eskow, and this is the Zero Hour.